Thank you, Bill, so much for having me. Emmett, it's really a pleasure and a privilege to be here. Those of you that know me know that it's actually a miracle that I'm here. About 2 years ago, I had a little medical problem that they had to sew in 2 inches of my aorta, and they had to freeze me to do that, and because they can't get anything in your blood for about 20 minutes. And so when you wake back up after about 8 days in coma, it's like dropping your cell phone in the water. And after about a week, it works, but nothing is quite the same. So you'll have to apologize. I'll have to apologize if there are times where my cognitive skills are pretty good, except for name recall. So if you come up and I look like I can't remember, you know why it is. I was frozen, and I use that excuse on my wife every day. I was frozen, dear. So my job is to talk to you about cataract surgery. And what I want to do is 2 things: give you a little glimpse of the future and try to talk a little bit about the opportunities that are available to all of us as this comes up. These are my consulting relationships. The first thing I want to show you is the market. Now, cataract surgery right now, and these blue dots come to you from MarketScope. You'll see that in 2007, we did about 3 million cataract surgeries that year. And in 2011, this past year, we did right at about 3.31 million cataract surgeries. Now, what's interesting to me is the baby boomers turned, the first class, of which I was a part of, turned 66 this past year. Now, 72 used to be 10 years ago the average age of the cataract surgery patient. Now that's dropped down to 66 because of all of the improvements, the safety issues we talked about. But the effect of the baby boomers is right here. And what you see, it's minimal. It's going to increase right at about 100,000 over the next 10 years. But the biggest change is what we heard about in the last session, and that was that cataract patients are now beginning to lower the bar for how much disability they have. In other words, the age is becoming younger and the severity of the cataract is becoming less because the success and safety of the operation is so good. And what we see is this is what the numbers are. Within 5 years, we're going to see between a 7 and a 16% increase, and by 10 years from now, we're going to see a 20 to 34% increase in the volume of cataract surgery, and those numbers are based upon the lowest and the highest increase that we've had over the past 5 years. So the market is very bright in terms of the volume. Now, what are the areas that are going to be affected in cataract surgery that we need to work on over these next 5 years? Well, the brightness acuity tester, which I invented in 1976, 37 years ago, has enabled millions of patients to have cataract surgery because our standard was you sit in a dark room and look at a black and white chart. Well, patients with posterior subcapsular and pretty severe nuclear sclerotic cataracts could see 20/20, and then they'd walk outside and all of a sudden they couldn't see anything. Well, today, 37 years later, we'll have newer instruments like the ones from Visiometrics called the OCUS, now the HD Analyzer, that measures light scatter. Wavefront doesn't measure that, visual acuity doesn't measure that, contrast sensitivity doesn't measure that. But light scatter, it turns out, is the one that is the highest correlated with cataract severity and the disability that it achieves in a patient. So we'll see more and more of these devices as we go forward that objectively measure the disability of a patient as a result of their cataract. Now, the components of cataract surgery, as you see here, are surgical techniques, the IOL calculation, that is hitting the target refraction that we want for that patient, and then the improvements in the intraocular lens itself, its design and its performance. And this equation that's 130 years old is the equation that we use for calculation, so there's not a new formula. But what we know are the axial length, the desired postoperative refraction, and the corneal power. But this ELP, the effective lens position, we don't know. We have to guess at that, predict it, if you will. And that effective lens position is shown right here. It's the distance from the corneal vertex to the intraocular lens. And in 1980, Binkhorst was the first one to say, gee, if eyes are a little longer, we'll make that value a little deeper. And in about 1988, we developed what we call a two-variable predictor, which used axial length and K reading. And then as the years went along, more and more people got involved, and we got about 7 variables to predict this, but it's still not on the button. We still have 50% of the patients that were within plus or minus a half a diopter. Well, that's not enough. In refractive surgery, it's got to be a quarter, and cataract surgery is the same way. Well, what's going to happen? Well, we have better imaging techniques today. We've got B scans with high definition. We've got Scheimpflug, OCT. All of those allow us to see, here's a pre-op picture of the cataract. Here's a post-op picture of the lens. By measuring the anatomy of this patient, where the angle is, where the structures, the zonules, we'll be able to figure out formulas, and that's where we are today, of where that lens is going to end up exactly. But there's still going to be some problems with the being precise, simply because there's some variability in how the surgeon puts it in and how the zonules relax. And so the point is that those imprecisions are still going to lead to some variability. Now, toric IOL calculations today are not exact either. And it's simply because the commercial calculators use a constant to calculate what the toric lens power, and it's not a constant. For a 2 diopters of corneal astigmatism, you need 3.5 diopters for a 10 diopter lens, 2.4 for a 34, and 2.9. Well, that again is about a 1 diopter variation, and more calculators will happen over this next year or two that will become exact, that give us the exact value for the toricity of an intraocular lens. Now, that's very important to us for this reason. You see here that as we look at the number of premium IOLs, which include toric and multifocals lenses, we see it's reached an all-time high of 14.5%. Well, 7.2% of that is presbyopic lens, multifocal lenses primarily, and you see that's been flat for almost 12 quarters, 3 or 4 years. And the biggest increase in the premium channel lenses is definitely a result of toric IOLs, and it's because of a shared billing thing, and that is the doctor does not have to bill Medicare for that. He can upcharge the patient and charge for the correction of that astigmatism. And as a result, you're seeing premium channel IOLs, specifically toric IOLs, increasing dramatically, and they will continue to do that as we go forward. Now, the one thing that is going to nail the refraction of that patient so that we have it on the button, even better than refractive surgery, is what we call an intraoperative aberrometry, or intraoperative measure of the refraction. In other words, rather than waiting till we get the patient back in the clinic the next day and measuring his refraction, we can do it on the table. And we can do it before we put the lens in. And in fact, the Aura, the orange by WaveTech, does that now. It turns out that when the doctor goes to surgery, takes a lens, he actually does this measurement, gets the aphakic refraction, and 60% of the time, they change the IOL that they brought with them to surgery to the one above or below the value that they'd predicted, and have lowered the mean absolute error in that refraction by a factor of 2, from basically about a little over 0.5, as I was saying, down to 0.3 diopters of error, which again exceeds what we get with refractive surgery. Next slide. Now, the cataract surgery itself involves making the incisions, which we're going to talk about femto cataract surgery here, phacoemulsification, which Charlie Kelman developed and is still the way to do it today, IOL insertion, and then the intraoperative refraction that we talked about to get us right on the button. Now, femto cataract surgery, the cataract surgeon makes a primary incision. He makes a secondary incision to put the second tool in. And here we have a picture of this. The primary incision right here, it's trapezoidal, bigger on the inside usually. Secondary incision is right here where he puts the instrument to help manipulate with both hands. Right here are two arcuate incisions which will eliminate the corneal astigmatism. And then finally, he makes a capsulorhexis that's absolutely circular, and he ends up softening the nucleus to make it easier for him to remove the cataract. Can you click that movie real quick, please, sir? So what we see there is, this comes from Steve Slade. I stopped doing cataract surgery a few years ago. And what you see here, Steve's lining the patient up. Femto, or short wavelength lasers, are going to be the way I predict within 5 years that all cataract surgeons are doing this procedure. You applanate the eye. Right up here we see that applanation. That applanation is because femtosecond energy doesn't go through air. We need to go through water. And then what happens is we see that primary incision, the secondary incision. Now watch it, because it's going to happen pretty fast. The capsulorhexis will be absolutely circular, and then we'll soften the nucleus, and all of that's going to happen in just about a few. He's done it in terms of now. Boom, boom, capsulorhexis, soften the nucleus, and now he's made that arcuate incision down here to eliminate the astigmatism, and he's going to make another one right up there to eliminate the incision. And then you'll see it's not open, so at the end of the case, he'll actually take and go in, open up those little things, and that is something that the cataract surgeon today has been afraid to do. The refractive surgeon, it's easy. We've been making AK incisions forever, but the cataract incision is something he's familiar, but not the AK, the arcuate incision. You can put two little arcuate incisions of a given length in the steep meridian and make that cornea round and eliminate that, but it's not as easy as it looks. For a lot of cataract surgeons, just a little tremble, that thing looks like a little worm track instead of a little AK, and you don't get good results. Well, the femtosecond laser can do that so precise, the same each time, the same depth, everything, so that all that's eliminated. And so I will predict for you that not only because of the accuracy, which will prove that it's better procedure, it will also be the reason that they switch is because of the patient's perception of laser surgery versus the knife. The knife, the same transition we went through with refractive surgery when femtosecond made the flap, will have the same exact course of action for cataract surgery. Now the IOL design. The design of the IOL, we've got adjustable IOLs that Calhoun is working on now. We can fine-tune the power and the toricity, and we're going to have mechanical lenses that work with fluid chambers that change that we saw at this meeting last year, and we're going to have electroactive IOLs that will allow us to change the power of the lens in the eye. Now, true accommodation, which is the holy grail, is basically something where the crystalline lens increases in power and it moves forward a little bit, increasing its effective power. That's what we mean by true accommodation, and that's what we have to have. And as I said, these are the mechanisms by which that work. One of the companies I'm working with that uses a pixelated optics, it's a Lensa. If you have these little pixels in here of glass that are inside an intraocular lens, you can actually pass a current through those and change the power of that active element by 3 diopters. The result is you put that little wafer of electroactive material in a parent IOL, and this is the example of that one that they've developed already. And the situation is, here's your electroactive element, here's the actual parent IOL around it, here's 2 little batteries in the edge of the haptics, and this little microcircuit that senses whether your pupil gets small and the light level, so that when you walk outside and the pupil gets small, it doesn't think that you want to look at something up close. It knows that because the light stays the same, that you're still looking at distance and you walked outside. But when you look up close and the pupil gets small, it pops in that extra 3 diopters of power, and therefore you can see, and it looks like this in the eye, and the first man implant will be in April of next year. So, and in order to charge that battery, you put this little mask on at night, you sleep with it for about 2 hours, and all of a sudden your battery is recharged. And if the battery dies, the worst case is you still got distance vision, you just don't see up close. So there's no downside to that. So what do we have on the next 5 years of cataract surgery? Well, the first is, as I said, the increase is going to be roughly 12%, somewhere between 7 and 16 over the next 5 years, partially due to the baby boomers. They'll be 20% of our population by the year 2030. But the biggest reason is because we've decreased the age and the disability that a patient has to have before they have cataract surgery. Femtosecond and short wavelength lasers will be the predominant form of surgery, and we'll see a small decrease in toric IOLs because it's so easy for the cataract surgeon to basically program the arcuate incision, and it's easier, he doesn't have to pay for a lens. Newer IOL calculation formulas with adjustment are going to happen, but the biggest thing is the intraoperative measurement of that refraction is going to happen, so you'll know before tomorrow what the patient's refraction is and have no more refractive surprises. And finally, the Holy Grail is getting close. Within the next 3 to 5 years, we will have devices that allow us to have good distance, good intermediate, and good near vision with no loss of contrast, no halos, and no nighttime dysphotopsias. So the future is very bright. I'm so pleased to be here, and I'm so glad to be a part of ophthalmology. Thank you all so much.